Yeah, good evening, everybody, and a warm welcome to our complex PCI conclave, which we'll be doing this evening. And we have with us three eminent speakers in form of Dr. Aisha Kadir from Dhaka, Bangladesh. We have with us Dr. Gaurav Agarwal, who's a colleague of mine from Narayana Health Parasat, and we have with us Dr. Dibyaranjan Behra, who will be joining soon from AMRI Hospital, Bhubaneswar. And our team is led by our expert, Dr. Shubhanand Roy. So let me talk a little bit about Dr. Shubhanand Roy, who does not need much introduction. He is a very well-known senior interventional cardiologist, not only in our region, but nationally. And he has more than 25 years of experience in all kinds of complex interventions, including left main stenting, rotablation, coronary imaging, primary angioplasties, CTOs, and he has also developed some techniques which is very much of his own, which has been recognized worldwide. And he has numerous publications in national and international journals, and also involved in many path-breaking clinical trials as principal investigator. Besides that, he's a very good teacher and a mentor to so many students who have been through his system and all across Eastern India. And I am a very good admirer of Dr. Shubhanand Roy. So welcome to our program, Dr. Shubhanand Roy. We also have with us Dr. Aisha Kadir, who is a senior consultant cardiologist at Ibrahim Cardiac Hospital and Research Institute. And Dr. Kadir has been traveling quite a bit. She was telling me she's just completed a course in clinical research at Oxford, which is a very intense course, 3-year course. And she's one of the renowned cardiologist in intervention and in Bangladesh, is doing very okay. She says she's associate consultant. I beg to correct myself, but she has been doing very good work in the field of intervention in Bangladesh, and a very well known person, and also an extremely good speaker, which Dr. Shubhanand Roy will agree with me. And we have been very obliged that she is with us to share a case. We also have with us Dr. Gaurav Agarwal, who is consultant interventional cardiologist at Narayana Health Parasat, a colleague of mine who's been doing very good work at that center. And Dr. Dibyaranjan Behra is senior consultant cardiologist, interventional cardiologist from AMRI Dhakuria. AMRI, I beg your pardon, Bhubaneswar. He's been also doing a great bit of work and a lot of innovative stuff in Odisha for the first times. So he'll be joining us very soon. So we have a bouquet of cases, which will be started off by Dr. Kadir, and I think she'll be talking first on a complex case of bifurcation stenting. Is that correct, Dr. Kadir?
Yes, it's a bailout.
Bailout bifurcation. So let's hear from her. Maybe a few little words from Dr. Shubhanand Ray first, and then you can start while you share your screen. Dr. Ray.
Thank you very much, Binayak. When you say something so nice about somebody, it is really, make you very small, and I feel very small about. But I must say that I have been working with so many anchors, and perhaps as a moderator and an anchor, Binayak can be compared to anybody like Shomi Mehta, and about their status, and even better sometimes. So this is a very wonderful opportunity to share your knowledge and to learn something from your juniors, and also when they're in the panel, there are very important people and important young people. I must say that Aisha and also Dibbo and Gaurav. Yeah, they are all very, very avid thinkers and excellent workers. I know them. Most of them I know. And so I'm waiting for a very good learning experience from them. Thank you.
Over to you, Aisha, for your presentation.
Thank you very much, Dr. Deb and Dr. Rai, for your kind words and very kind introduction. As I was saying earlier offline to Dr. Deb, this is a case that I also learned a lot from, which I had the pleasure of working with my mentor, Professor Said Rahman Khan, from whom I'm still learning quite a lot. And this was a 78-year-old gentleman who was ironically the father of a doctor. He was hypertensive, dyslipidemic, diabetic, and presented with intractable angina over the last few weeks, which persisted despite being on optimum guideline-directed medical therapy. However, he had a good, well-preserved ejection fraction. ECG did not show any abnormality, but came with persistent angina. And this is his angiography, which we approached by a transradial route. Except for a very discrete and tight lesion in the mid-left circumflex, there did not appear to be any significant stenosis requiring revascularization. As you can see, that's the tight circumflex lesion. And there's some mild to moderate disease in the mid-LAD. And even in the RCA, the distal RCA there seemed to be a moderate lesion, but with the good non-flow limiting disease. So we decided to stent to go ahead and revascularize this discrete left circumflex lesion, and it seemed like it was an easy thing to do. So however, even during engagement of the guide, we found that usually it's I tend to use a JL guide, but in this case, as you can see, even though it wasn't a very distal circumflex, we required a 6 French extra backup guide, and we will see later how lucky it was that we had a 6 French guide and with extra backup support. So engagement wasn't particularly easy, nor was the wiring. As you can see, a circumflex is, as a learner, I found it was one of the most difficult vessels to learn to wire up front, and that proved to be right as well. And we went ahead and did pre-dilatation because it was quite a tight stenosis with a small 210 balloon. And this is the next picture. This was just after a very minimal inflation pre-dilatation, and you can see that the guide is also protruding quite a bit into the left main. There appears to be a dissection, could be overridden with thrombus, but just at this point, very rapidly, things started sinking, and the patient was also deteriorating hemodynamically with ECG changes. There were ST elevations on the leads, and also the patient was complaining of chest pain with deteriorating hemodynamics. So this is where the strategy changed from something that appeared to be a very simple, straightforward type A lesion into something that we needed to bail out. We were thinking what went wrong. It's to this point, perhaps I could weigh in on your expertise to figure out what went wrong, but it appears to be a dissection, a catheter-induced dissection, and how in a stable angina so much thrombotic burden appeared is also a mystery. But rather than assuming or trying to guess what went wrong, we needed to restore the circulation as soon as possible. And therefore, although the LAD was not wired, we decided to go ahead and wire the LAD immediately, and also gave intracoronary GPI. So as you can see, although the patient was given eptifibatide and the LAD was wired, there still appeared to be that hazy thrombotic burden in the left main bifurcation. Things seem to be getting worse. This is probably a dissection also. So after wiring the LAD, the next step was then to figure out, this is the thought process that we thought what to do. Imaging to judge what is there would have been a good idea, but this patient would probably not have allowed the time to take an IVUS catheter down to figure out what was wrong, because there was rapid deterioration and there needed to be a bailout. So in keeping in mind a two-stent strategy that we might need, we decided to go ahead and stent, but then which vessel to stent, whether to do the left main to circumflex, where there was a de novo lesion at the beginning, or whether we do left main to LAD. Having seen this picture, and also given that the main lesion that we found was in the left circumflex, we decided to proceed to stent into the left main to left circumflex, keeping in mind the potential need for an inverted tap downstream later on. So the left LM to LCX was then stented with a 3.5 30 millimeter drug-eluting stent. And the next thing we see is that the LAD is now totally occluded with residual thrombotic burden and probably some propagation downstream from near that ostium. So even though we had stented one part, it appears that the LAD was further deteriorating. Sorry, I'm just trying to run this. Yeah, so ideally in a case of bifurcation, this is the point where we would do a pot so that rewiring would be easier. But as this patient was, again, acutely hemodynamic, we had to do certain modifications that were unorthodox. And instead of a pot, therefore, we rewired immediately, again, gave cocktails of nitrate as well as a little more eptifibatide, and then took a small 2.5 10 NC balloon to pre-dilate the LAD and see where we would land the stent, because as it is at this point, we don't know even how long of a stent we needed to choose. After pre-dilatation, we then saw that there was this additional lesion, which of course did not appear to be present in the initial angiogram. And although TIMI-3 flow was established, we now know that we also needed a long stent that would cover both that almost mid-LAD lesion as well in this inverted tap technique that we were going to adopt. So the mobilization of plaque from here and there, and despite the fact that medical therapy was given in the terms of nitrate and eptifibatide, we needed an extra long drug-eluting stent for this inverted tap. So here, now that we had established TIMI-3 flow, we decided to do a pot to optimize the left main to left circumflex stent within the left main, and then took a very long drug-eluting stent, 2.75 38 millimeters. So here the LAD was functioning like the assigned side branch, and went ahead and stented it, keeping a balloon within the left circumflex. So this balloon was then pulled back, and using the in situ balloon of the stent within the LAD, we did a kissing balloon inflation sequentially up to 12 atmospheres. Followed this with the 410 final pot in the left main. And this is when this patient stabilized, and we decided we could go for an IVUS run, which showed a satisfactory result with good stent apposition and no residual dissections present. Not sure how long this run might be. Yeah, it's almost done. And this is the final angiographic picture with good distal TIMI-3 flow, but a bailout two-stent strategy in what appeared to be a seemingly easy lesion. So in conclusion, the learning points for me in this case was that a provisional strategy is always, of course, adopted, but in case of a side branch becoming as heavily compromised as this, we need to think of a two-stent strategy, and we then need to also very quickly assign which is the main branch that we would use and which is the side branch. Ordinarily, left main to LAD would be the main branch, but according to the latest EBC also, they have defined what is called the assigned side branch, because sometimes you just need to assign the other vessel as the side branch, which we did for the LAD, and treated the left main as the main branch here. In upfront two-stent strategy is mandated, fulfilling definition. Choice of technique is still flexible. TAP is probably one of the easiest in terms of bailout. It is quick, and it is also something that is very easy to learn relative to the other two stenting strategies. And although all the trials highlight the importance of operator expertise in the choice, as I mentioned, it's even more relevant, especially in emergencies and bailout. And what they say still stands true, that to learn one bifurcation technique very well and to apply it as best as possible. And thus, bailout two-stent strategy by TAP is convenient and appropriate strategy in such cases. And the best approach, particularly when things go south, is the KISS principle, which is to keep it simple, safe, and swift. And with that, I would like to thank you for listening, and I look forward to your comments on how you may have approached this case as well. Thank you.
Thank you so much, Aisha, for your lovely case. I think there's so many points for discussion. So let's start with Dr. Shubhanan Roy, his comments.
This is a wonderfully finished case, I must say. But there are a few certain points that, particularly if this case was my case, I would have dared to do it radially, seeing the guide catheter, placement. Because at my age, I do not, accept so much of adrenaline rush. So the problem of, EBU catheters and the XB catheters in our small frame people is that perhaps this was EBU 3.5. Perhaps you could have taken an EBU 3, because if you look at the trajectory of the EBU, your guide catheter were touching the upper roof of the LMCA towards the LAD.
Yes.
So it was hinging inside the left main and hitting the junction, carina of the LAD and LCX. So this type of guide catheter placement, and you are trying to wear the circumflex. When you pull up the balloon from dilating the circumflex, the guide catheter hinged into your LAD and created a dissection. Now, the second point is, and so I always say, and to myself also, see the guide catheter first. If the guide catheter is coaxial or it is placed in a safe way, then proceed, otherwise go in another way. So this is number one. Number two is, when there is a dissection and you know that the thrombus is sitting on a dissection, whatever the source of thrombus is, if there is a dissection, you cannot risk any branch. And in particularly left main, both the branches, both the circumflex and the LAD, both are main branches. No one is side branch. Both are equally important. So if you see that the LAD is, there is a risk of LAD to be compromised after the left main, after the circumflex stenting, you should have, in that case, you should not go by what your textbook says about provisional stenting. You need to dilate that. Your patient was going down. There was hemodynamic compromise. You need to have a kissing balloon dilatation first at both the ostium, so that you stabilize the patient first. Then you plan what strategy, whether you should take a IVAS. Do not give too much importance to IVAS. First, the patient should be alive. Then you do whatever is possible. You do an IVAS and you do everything. So first is dilatation of both the branches. And perhaps when we started way back, when Vinayak started, myself started, there was only balloons. So in that situation, we would have done a prolonged balloon inflation in both the LAD and LCX as a kissing balloon, and that would have stabilized the patient a little bit. Then you plan, then you put a stent, and then every step is perfect. But these two are the very important steps where you went wrong. This is my comment. Otherwise, the case is a fantastically finished case. There is nothing to say about it. It is all textbook. But these two areas where I think I would have not, done that.
I ask a question to both Shubhanand Roy and Aisha. If you thought that there was a dissection of the LAD and LAD being LAD, would you think of actually stenting that artery first and then taking a call on the circ, which was reasonably all right at that point of time? Aisha, yourself first, and then over to Dr. Ray.
I probably would have. The thing is, it looked so much like thrombus, and on retrospective view, we see now that it's quite clear there was a left main dissection, and it was definitely not coaxial. It was hitting the roof of the left main towards the LAD. So probably that might have been a step that would have stabilized them better. But I also take in Dr. Shubhanand Roy's very pertinent points, like some of those things, like perhaps a kissing balloon inflation would have stabilized both vessels in one go, because that would a prolonged balloon inflation, as we would treat any other dissection, say in any other vessel, And in the left main, a kissing balloon inflation is would probably have been the way to go. Retrospectively, I agree. I would probably have stented the LAD because that's very likely the direction in which the dissection started.
Dr. Ray?
Vinayak, once you stabilize the system, when your hemodynamics is stabilized by doing a kissing balloon or anything, then you have an option whether you go to LCX or you go to LAD. But yes, what at that point she thought that yes, the LCX she has done, and it would be easier for her to go to LAD. That I do not say against it. It can happen because both ways you can go. But the point is, LAD is a very important artery, no doubt. But in left main situation, both the branches are important. It is not that it is not LAD-D1, and also I do not call it a reverse tab. I call it a tab. If it is a LAD-D1, I would have called it a reverse tab. But it is a tab because both the branches are of equal importance. This is number one. And number two is, circumflex ostium was also diseased because the guide catheter hit the carina and causes dissection in both the arteries. Both the ostia was dissected. The LAD was dissected and also LCX was dissected. So in either way you can go.
I think there was a point of luck because I think the reason is, I'm telling you, once the circumflex was successfully stented, we saw there was no flow at all in the LAD.
Yeah.
So that was where the patient could have crashed completely. And that would have created a mayhem, absolutely. So I think, as you mentioned, stabilizing the patient, both the arteries are so very important before we even think of contemplate of stenting at all. So that is something which we absolutely procedurally we will take notice of. And I think the other thing is the need for the proper guide catheter and handling of the guide catheter. I think the guide catheter was hitting the roof all the time while it was engaged, but I think the dissection must have happened when the balloon was pulled. So that might have caused that traction and negative pressure and to cause the dissection. And Dr. Ray is absolutely right. I think both the ostium of the cervix definitely also a part of the dissection. So there was a lot of factors which were there. I think the case was wonderfully done, but there were so many learning points, Aisha, I think, from these cases, right from the choice of the guide catheter,
Right.
handling of the guide catheter, and I think then the options. Dr. Ray, in your expert opinion, do you think, except TAP, there was any other option which, some people, they talk of a lot of other techniques in these cases. Obviously, in this particular case, you don't have much choice because it was an emergency. But otherwise, would you have thought of any other kind of techniques for handling this,
Actually,
not this particular case, but at a case of this magnitude?
Actually, if the hemodynamics is too bad, if there was an arrest or if the hemodynamic is too bad, I would have gone for 2 stents and do a case and come out. Because there you need quick, restoration of the flow in both the blood vessels.
You're talking about Coulomb?
No, just SKs. Putting 2 stents together.
2 stents and come out.
If there is an arrest or something in the bad hemodynamics, you need to do something. I would have done a SKs and come out, because that is the only stenting, strategy which needs least, time, perhaps.
Okay. Dr. Kader, what do you think yourself?
Yes, no, that's a good idea. An extension of the kissing balloon inflation is the simultaneous kissing stenting. So I learned a lot from this discussion. So thank you very much for the opportunity to share the case, and also thank you so much for your comments and expert opinion.
And I think the other thing we might also, for the experience of the viewers and listeners, that the T technique, the that is something which is really obsolete. We should not be discussing that technique at all, because the 90 degrees is an illusion. It's an absolute illusion. Coronary illusion. The maximum illusion I tell is actually a coronary illusion when we tell that our carina is 90 degrees. So I think the tap technique is the only technique which we should consider, and not the T stenting technique. Do you agree, Dr. Ray?
Yeah, basically, tap is an extension of T.
Yeah.
So, basically tap was created to bail out the deficiency of T. So tap in good hands is a very good technique. I must say that. But you must be very particular in placing the stents and also, doing the things properly step by step.
And also the pot, I think the final pot is also so very important, where you place your distal end of the pot balloon.
So if tap is done properly, it's a very good stenting technique.
We have with us Dr. Dibyaranjan Behera, he's senior consultant from AMI Hospital, Bhubaneswar. And Dr. Behera, welcome to our show. Have you had the opportunity to see Dr. Wonderful case of Dr. Kader, or you have just joined?
Yeah, such I missed it.
Okay,
so I hope I could have
so let me ask you, as an operator, what kind of bailout techniques, two-step technique, two-stent techniques do you look forward to? Is it a tap?
Yeah, for left main, that already sir Subramanian sir told that for left main with hemodynamic instability, there is no other second choice other than SKS. That is the life-saving for any patient. If the carotid is dissected, particularly both LAD and SOR complex are compromised. But if the patient is stable, you can go ahead with constant technique LAD to L6. So considering that L6, left main to LAD, and considering L6 is a small branch. But for left main, I was telling that L6 is always important, whether it is small or big. In case of LAD1, you can still consider one stent technique, but I think SKS is good for any hemodynamic compromise case.
So, Dr. Kader, how is the patient doing?
Patient is fine, has come on follow-up.
Yeah.
Father of a doctor, so on regular follow-up, and it was quite an adrenaline rush at the time, but he's doing well. This was about 6 months ago, this case, so he's been well and alive.
The other thing which I wish to ask Dr. Ray, in his opinion, when you are doing cases in a rush, in cases like this in an emergency, we often don't give much concentration on optimizing the stent apposition and expansion and all this. So how do you factor in these things? Do you come back later and image them and see them, or what do you do for these cases? Because of course, the outcome of a case where you have optimized properly with imaging and the stent apposition is very, very good, versus in an emergency where things have to be done in a rush, things are obviously different. So outcome-wise, how would you kind of compare them?
Basically, in an emergency, first and foremost thing is to stabilize the patient, whatever is there, And if you want to stabilize the patient, you plan it out step by step. You do a balloon first, restore the flow. First is restore the flow, either by a balloon or anything. Now, once the patient is stabilized, then you plan. So, in all my cases where in an emergency, I have done say something in left main, left main dissection, I put a stent across the left main. Once the patient is stabilized, I do keep the patient on the table for some time, observe 15-20 minutes, half an hour. After that, I put an IVAS catheter imaging to see that whether whatever I have done, it is proper or not. Then, if something is added, I do it and come out.
That's exactly what Dr. Kader has done. The team have done is actually waited and done imaging and not rushed out of the cath lab just because they have saved the life of the patient. So I think this is the point which I wanted to kind of reiterate, that once you have finished the case and the patient is stabilized enough to undergo coronary imaging, I think we should finish the case as if we are doing an elective case, so that your outcome, short-term, medium-term, and long-term outcome is equivalent to a elective case. So that is something which we all need to keep in mind. So thank you, Dr. Kader, for this wonderful presentation. I would extend you to stay for this entire course. We'll have Gaurav. Are you ready with your presentation, or I'll ask Dr. Behra to do his case next? Dr. Agarwal?
Sir, if Behra sir is ready,
Yeah, Dr. Behra is actually ready with his case. So
sure,
can we start?
then
Yeah.
I'll finish up both the cases at the same time.
Okay, fine. So Dr. Behra will actually talk on a calcified lesion, angioplasty. That's what you're telling, Dr. Behra, isn't it?
No, sir. Actually, I am also showing a case of left-hand bypass.
Okay, you're showing a left-hand bifurcation. Okay, so we'll see Dr. Behra's case.
Yes.
So he doesn't need much introduction, as I've introduced you, Dr. Behra, before. You're doing wonderful work in Odisha, and he's one of the pioneers for a lot of things which is stuff he has done while he was in AIMS and then some hospital and now in AMRI hospital.
Sir, thank you, Binayak sir. As always, you are always a mentor to me, and also good evening, Dr. Ray sir. I also learned a lot from you in this online forums, and thank you and everybody from Abbott and all my other participants. So today I am also going to present a case of left main bifurcation. So is my slides visible? My slides visible, sir? Okay, sir.
Yeah, we can
Yes,
see
we
you.
can see.
Sir.
Yeah.
So this is a case of 70-year-old male presented to us with a sort of angina, which is very much interfering with his daily life. Class 3 angina, good LV function, sinus rhythm, hypertensive, and smoker. So this is the angiogram. And see that left main is bifurcating into LAD and circumflex. So there is at the bifurcation point there is a lesion, mostly Medina 111, and he has also significant stenosis at the proximal as well as mid circumflex. You can see that two other lesions are there. In the mid LAD, just after the diagonal, there is a intermediate kind of stenosis. But in some other views, like areocranial view, it starts like around 60%. So I thought it's not that important now. But the other lesions like circumflex 2 lesions are looking significant. And this is the right coronary artery, which is okay. So in this situation, what should be our plan? This is a Medina class 1-1. Both circumflex is quite big enough. LAD, left main bifurcation. So definitely a two-stent strategy. What I think, because circumflex proximal and mid region is already there is significant stenosis. You have to deal with that also. So in that case, definitely you have to go for circumflex as a total, including the ostium. So for this case, I also planned a decay cross or whatever you call it, maybe a nanocross technique. So I took this is completely radial approach, 7 French guide. Then I wired both the vessels. So just to measure what is the length of the circumflex, just took a small angio. Then I dilated, first pre-dilated the circumflex lesion, mid and proximal circumflex. Then after dilating, this is the scenario. Then first I put a mid circumflex stent. Then I put a stent across the from left main to circumflex ostium, but keeping another balloon from left main to LAD, so that that it will just cover the ostium. So different, this is the most important part. We have to adjust it before we go for impression of the stent. So this is how I placed the stent across the ostium, so that only one or two struts, just a minimal one strut will cover the ostium. So with that, I inflated the circumflex stent, and then I removed the wire and crossed the whatever protruding struts. I crossed the stent. Then again recrossed. Did the first case. Then with that same balloon, I post-directed the previous liquid stents. Then I put a stent from left main to LED. That positioning, because I need at least 8 millimeter stent in the left main to do a pot. So then I inflated this stent. This is 3.5 stent. Then this is just after the. Then I again recrossed. Then I did the this is the second case. Then the LED stent was post-dilated. This is the 4 mm balloon. And so this this was the pot being done. Okay, let's see that 4.5 balloon into 8. So this is the result after pot. Sorry, this is another pot. Then again I did the pot. So this is the result. So that's all, because this case was done under that Odisha government scheme. We don't have the things to do IVAS or imaging. And this patient is doing well for last 3 to 4 months. And so that is a case of left main bifurcation with decay cross and maybe sort of non-obstructive.
Thank you, Dr. Dibaranjan Bera, for your wonderful case. We'll start with Dr. Shubhanan Ray for his comments, and then we'll ask the other panelists to join in. Dr. Ray?
This is a very wonderful case. And the end result is really fantastic. But basically, 2-3 things are important. Did you prepare the bed nicely in LED and LCS? What balloon you used in the LED ostial dilatation?
2.5 NC at high pressure.
I think the LCX LED ostium is 3.5 maybe.
Yeah.
So if you use a NC balloon, you can use a quarter size smaller balloon, but not, you know what? But the ostial lesions are sometimes very unforgiving.
So,
So
sir, actually, during 2.5 NC balloon, then at the time of crossing, I used a 3 mm NC balloon for crossing.
I know that, but that is not the way out. Basically,
Yeah.
if you see that, if you take a 1:1 or less than quarter size less for the ostial LED, you'll be able to open the LED in the right way. Otherwise, if the LED does not open nicely, say with 2.5, there will be a false sense of security. You just open the balloon with 2.5, it nicely open. Then you when you put the stent is not opening. I mean, that happens.
Yeah.
So basically, in two stent strategies, when you do a two stent left main strategy, you cannot, I mean, compromise with every step. You have to be very particular in every step. Otherwise, the results will never be very optimizing result. So I would have opened both the LED and LCX nicely. First of all, is this. Number two is this is not a nano crash. This is a decay crash, perfect decay crash. It's okay, no problem in that. Decay crash is also a very good this thing. But the point is in a decay crash and nano crash where there are one stent is crushed, it is better to make the branch which has the longest stent as the main branch. Why? If the side branch is very long, if there is a turbulence at the ostium, you never know that whether there is a turbulence at the ostium or the side branch, because that it is. And there, if you look at the computational fluid dynamics, the turbulence, there will be some turbulence. You cannot make an absolute, no turbulence zone. There will be some turbulence at the ostium of the side branch. If the side branch stent is very long, that will cause flow diminution in the side branch. So there is a chance of restenosis. There is a chance of ostial stenosis, which can happen if your side branch stent is very long than the main branch stent. So it's better to have a long stent in the main branch and short stent in the side branch. Though this is a very, you can call it a soft this thing, but this is hemodynamically more, optimizing situation. This is two. And number three, IVAS is a must for a two stent left main. There's no doubt on it. These three are my points.
Yes, sir. Thank you. I think that second point is very noteworthy, that the long stents would be the main branch. But suppose here it is a circumflex.
So we make it a main branch. So what? I told you that in left main, no one is a main branch. Both the branches are important. So the longest branch, you should keep it, because we have, our hair is gray. Now we are old people. We have seen more disasters than, anybody can see. So we have seen that if you keep the side branch long, there is a chance of side branch problems.
Yes,
Dr. Kader, your comments?
Thank you very much, Dr. Vera. That was a very interesting case. And it's ironic because at the end of my case, I was going to take the opportunity to ask Dr. Shobhanan Roy, because he has done so many nanocrush and is a pioneer in nanocrush, about his experience of nanocrush in left main. Because one of the criticisms, so to speak, that people say is that there's every chance of missing the ostium, and that therefore in something as important as a left main, nanocrush should not be adopted. What is your opinion on that, sir?
This is not a comment. This is a comment which is very old. When we started, people thought that it would have missed the ostium. We did bench test and published. Then we did micro-CT, published. So nowhere it is documented that in nanocrush ostium is missed. And also, when we presented our data in EuroPCR, The chairman was Leward. Why Leward? And Dr. Leward said, you cannot call it a nanocrush. You call it a axial compression of the stent, where the ostium cannot be missed because it is entering into the main branch, and you are compressing the stent, okay, by another stent. So he said that it should be axial compression of the stent. Anyway, because in nanocrush, you cannot miss. If you do nanocrush yourself, and you will see that you will never miss it. We have done, I do only nanocrush. I do not do anything right now except, provisional. In provisional, I go for tap and pull out, etc. But if I think that I would be doing a side branch first strategy, then it is always nanocrush, always. And never I have seen that I have missed ostium. It is never missed.
I wish to
Irrespective
ask.
of the angle, sir.
Yeah, go ahead.
Sorry,
Dr.
just to follow up, it's irrespective of the angle, sir, even in
Yes, irrespective
wide
of the
angles,
angles.
nanocrushes.
Yes, why I can tell you,
Yes,
if there is a short dictum, that if you see that your angle is very narrow, a very narrow angle, then you will keep a balloon which is quarter size smaller. I mean, say if that is a 3.5 main branch, you keep it as 2.75. Okay. But if you think then an angle is not 50 degrees, maybe 70 degree to 90 degree, there I keep a quarter size smaller, like a quarter size larger. Like in a case of 3.5, I keep a 3. That is the dictum. So you will never miss it.
thank you very much.
This is a very generic question I'm asking all the panelists and the expert also, that there is a saying or a consensus amongst a lot of interventional cardiologists that when you're doing a two-stent technique, you have to be an expert in that one particular technique, and you should follow that continuously, irrespective of whatever comes. Are you a believer of that, or do you think that you should be knowing all the techniques and utilize the techniques as per the requirement of the case? First, over to you, Dr. Ray. Your opinion.
It is a wonderful point. I must say that one must be proficient in one two-stent strategy. He must be proficient, but he should also be proficient in a case for bailout. These two things he should know. That once, if you in elective situations, he will do this, and for emergency, he will have this, because two techniques he should be like, you plan out an nanocrush or whatever, decay crush, and you see that when you dilated the ostium, there is a huge nasty dissection, and the hemodynamic is compromising. So what you do? You have to monitor. You have to, renegotiate and re-strategize your techniques and all. And there you can go for maybe SKS, maybe mini crush. So that can happen.
Dr. Kader, what about you?
Yeah, I would agree, although a lot junior. I think it also takes time to develop the expertise in particularly two-stent strategies, purely because you also have to receive the volume in terms of training. So there's a lot of truth to mastering one technique, but Dr. Shavanan Roy makes a very good point that you have to be able to bail out. And I think something that might be useful is at least knowing very well the theoretical steps, so that in the event you need to bail out, even if you haven't actually done it, you know what needs to be done, because there's always also a first time for everything.
Vera?
Yeah, I almost agree with sir that we should know at least one technique to 100%, not 100%, as far as successful you can, so that you can master that technique very well. But you should always have a plan B in your hand, in your mind, whatever. suppose something happened, you can change your strategy, because sometimes one stent strategy, many times you see, suppose there is critical, let me circumflex compromise or something, person is in pain or develop BT or hemodynamic compromise. So we have to go for a tap, or that is called reverse tap or whatever. So many times after pre-dilatation, are telling there is some dissection at the carina, both the vessels. So you have to do a mini cross or an SKS. So as far as this elective post-stent strategy are concerned, most of the results are still with decay cross technique. So as the early part of career, I would still suggest that. And now, of course, Sarah has developed nanopose technique. It is almost similar, and very few struts protruding. So it is even better than that. So these two techniques should actually master, but be prepared with other things like tap, reverse tap, reverse cross, all those things. SKS, you should know every things at least. You should have knowledge, and at least you should have seen. If you have no idea, at least see some YouTube videos how they have been done. At least in mind, these steps are the steps should be there. You should only panic when something happened, and you should always go for the techniques.
Dr. Gaurav Agarwal, your comments?
Sir, I'm very junior, I think, and I'm
Doesn't
still
matter. You're
learning.
an interventional cardiologist. We are not junior or seniors here. As
Sir,
long
I'm
as you're in the
learning, I think.
business of doing intervention, you're in the equal podium, no matter what.
As Shonan sir said that you should be mastering at least one technique. So I'm still in the process of mastering that technique.
Good.
So once I'm done with that, I think then I'll be able to better comment upon that. And I think the presentation which I'm going to show, I think that will help us understand that where I am lacking, or what
No,
better.
we'll discuss about that. Don't worry about it. There is one more question. The good thing about this is because of out of 100 angioplasties, I mean, the bifurcation would say, I would say today in today's world would be about what? About 40% if you really are very honest about what you're doing. If you're doing dedicated bifurcation, about 40%. So 60% is straightforward single angioplasty. So when you're doing bifurcation, again you do 70-30. 70 is one stent, provisional stenting, and 30 is basically you're doing two stents. So you're left with really a 30% chance of landing up into a two stent strategy. So I think it is really very, very important that you expertise on an area where your numbers are actually low. So it's easy to get an expertise on an area which is where your numbers are high. But if you're doing in a normal cath lab scenario where we all work, where your numbers of two stent strategies are going to be only 30% of your whole case burden, then I think you all the more requirement that you are good at least one strategy, and also understand the other strategies as well. I hope, Dr. Ray, you agree with this?
Absolutely, absolutely. And basically what happens if your work, my work, and anybody's work, even in liftman, most of the liftmen we do by professional stenting, 70%. But still, there are areas where we need two stents, and for the beginners who start, I tell them that yes, go for two stent in situations which are safer. Like if you can start with a LED D1 bifurcation there, and you start as a strategy of two stent, there you make yourself perfect. Then you move to leftman. First, don't go for jump for leftman in the first go. This is too hot, situation. So,
I think this is an advice which is so important, because I think you have to start your career as a cricketer from tennis ball and go up to IPL cricket if that is your ultimate aim, where you're facing 150 kilometers per hour. But unfortunately, we see a lot of cardiologists who are new into the profession. They are taking up very daring cases and showing them in our meetings. I think this is a trend which needs to be actually curbed, because I think we require mentors. We all, during our training periods, we always learned that we do the easier cases first and then gradually go up into the more complicated cases. But nowadays, I think because your labs are so many, your number of cardiologists are too few, and I think young cardiologists are pushed into very difficult cases. I think this kind of trend is happening, which is a dangerous trend, I think. So I think it is very important for mentors like Dr. Shubhanan Ray and people like Dr. Kadir and Dr. Behra, who are actually going up the ladder to tell their students that, this is the way to learn difficult angioplasty. Because angioplasties cannot be learned sitting in the shore of an ocean. You have to really go inside it to learn angioplasty. This is a message, I think, which we need to give to our participants and the viewers. So, Dr. Agarwal, if you want to present your first case, and we take it from there. Can you share your screen, please?
Yes, sir. Sir, my screen is visible?
Yes, it is visible. We can see it. You can carry on.
Yes, sir. So, good evening, everyone. Thank you for this opportunity. So, I'll be presenting a couple of cases of left main stenting. Actually, both the patients are father and son. So, first I will present the case of the son, who was a 47-year-old male, who is a known case of dyslipidemia, and he presented to me with class 3 angina from last 2 years. And he had a normal LV function. And I took him for an elective angiogram. And as you can see, the RCA looks more or less normal. On the left shoot, you can see that there is significant stenosis of the left main. And because as soon as I hooked the left main, there was significant damping. So I disengaged the catheter. And then I have taken a non-selective shoot where you can see that the left main is critically stenosed, and the LAD and LCX look free of any significant disease. So then I discussed the entire scenario with the patient's relative, and then So then the patient was planned for an elective OCT guided left main stenting. We have done the OCT, but unfortunately I could not get the videos of the OCT. So I'll be presenting without the OCT images. So this is the patient. We have taken him for an elective angioplasty via the right femoral route. And this is the JL catheter. An important point that I think Dr. Kadir also mentioned, that usually in such cases, we should prefer JL guide as compared to EBU, particularly when we are dealing with left main. And most importantly, when it is a short left main, then I think JL will be safer. So this is a non-selective shoot of the left main, which is showing a critically stenosed left main, and the LAD and LCX look free of disease. And then we have decided to go on to wire from the left main to LAD. So because at this moment, I was not sure that what will be the length of the stent and whether I am going to go across the bifurcation into the LAD. So after doing a pre-dilatation of the left main stenosis with a 2 into 12 mm balloon, we did an OCT run, as you can see in the third video, but I don't have the OCT clips here. So it showed that the disease is exactly just limited to before the bifurcation of the left main. So I need not, prolapse the stent or go across the left main bifurcation. I could have just stopped at the bifurcation if I place the stent properly, and then there is no need for going into the fuss of doing a bifurcation stenting in the left main. So after the OCT run, we were confident that we'll do a isolated left main stenting and come out. So based on the OCT image, we got a lesion length of somewhere around 9 mm. And because it is an ostial left main stenting, we felt that a 12 mm stent will be okay, because 1 or 2 struts needs to be, prolapsing into the out of the left main ostium into the aorta. So what we had on the shelf was a 4 into 12 mm drug eluting stent. So that is what we had used. And after, multiple projections and checking the position of the stent in multiple views, we decided to deploy the stent from the ostial left main into the distal left main. And you can see here the stent inflating. And later on, we did a post dilatation of the left main stent with a 4.5 into 8 mm NC balloon. But what had happened is that the left main stent just crossed the LMCA bifurcation into the LAD. And what we saw on the OCT after stenting was that only one strut of the stent had, crossed from the left main bifurcation into the LAD. But the good thing was that the patient was hemodynamically stable. There was no thrombus or no significant carina compromise of the LCX, and there was no flow limitation in the LCX. So I felt that, there is no point of doing a crossover or complicating this any further. And because I had a good result and the OCT showed that the stent was well opposed and we had a good, luminal area, I felt that it is better not to complicate this anymore and just leave it here. So this was a straightforward case of a ostial left main stenting, which, it was unintentional, but had 1 mm of the stent had crossed from the left main bifurcation into the LAD. But as the patient had no complications and everything was good, looking good, so we decided not to intervene any further. And this were the final shoots. You can see the LAD has some minimal disease, and the LCX ostium looks free of any significant disease. There is a borderline lesion, maybe 30 to 40% stenosis of the LCX. But then again, because there was no ECG changes, patient was stable throughout the procedure, we left it here. So this is the son, who is a 47-year-old male. Now let's go to the father, who is a 68-year-old male, and he had class 3 angina from 1 year. So again, the RCA looked free of any significant disease. There was some 30-40% stenosis in the proximal RCA. And you can see from the left shoots that on the initial non-selective shoot, I was not able to, engage the diagnostic catheter properly. So I decided that I'll take a guide catheter and take the shoots. And you can see that there is some degree of calcification at the left main and LAD proximal part. And the ostium of the circumflex is having a tight stenosis with a aneurysm, which is confirmed with the guide catheter shoot. But the important thing to note here was that there is no reflux, totally zero reflux of the contrast from the left main into the aorta, and there was significant dampening here. But looking at the initial portion of the LAD looks free of significant disease here, but the circ is definitely tightly stenosed. So one question right at this moment, which I need to discuss is, what would have been the strategy here? Like go for a left main to LCX stenting, or go from LM to LAD? So next day I switched over to the right femoral root, and then with a 7 French JL guide, I took the shoots again. And here, if you see properly, there is some degree of reflux of the contrast into the aorta, and the left main does not look to have any significant disease. And here again, there is some degree of dampening. So that is when I felt that, okay, definitely there is some disease of the left main, but I was not sure whether it is significant or not, hemodynamically significant or not. But definitely the circ had, for the circ, we had to do something. And because it was a scheme patient, I did not have the, possibility to do intravascular imaging. So I had to do this with the routine cine and fluorography. So initially, if you see the cranial shoot here, you see that there is some 40-50% stenosis of the proximal LAD in the cranial shoot, but the mid and distal LAD look free of any significant disease. So at this moment, what I felt was that because there was dampening of the pressures whenever I hooked into the left main, and because the circumflex has a significant amount of disease, which has to be covered through the ostium. Like if I stent it, I will have to go through this ostium into the left main. So I felt that either way it is going in to land up to a bifurcation. And as we have been discussing till now, that for a left main, no branch is side branch. So both the branches become important. So I felt that, LAD will also be compromised eventually. So it's better that we also do something for the proximal portion of the LAD, because once I stent from the left main to LCX, the LAD ostium, which is having some 40-50% stenosis, will further, worsen. And so let's make sure that the LAD is also protected. So I wired into the LAD, and there was some degree of concertina. And then we decided to, stent first the proximal to mid portion of the LAD. The first mistake I did here was I took a very long stent. I took a 3 × 44 drug-eluting stent from the osteoproximal LAD to the mid LAD. This, I think, because of the concertina, I made that mistake. I think a much shorter stent would have sufficed here. And as you can see in the caudal shoots, I have positioned the stent just after the LAD ostium. So I deployed the stent there, and this is the immediate post LAD stenting shoot. So here it is not visible here right now very well. I think after the post dilatation you will see it better. But I felt that there is something happening to the LAD ostium. There was some degree of haziness here, and because I was taking non-selective shoots most of the time, so I was not. But because both the branches did not have any significant flow limitation, I went ahead and felt that first let me post dilate this LAD stent. We'll go step by step. So I did a post dilatation of this LAD stent with the 3512 NC balloon. And here, if you see in the cranial shoot, you can see at the distal left main and the LAD ostium, there is significant narrowing, which is much visible here. If you see just at the bifurcation, there is significant narrowing, and this might have been overestimated because of the overdilatation of the proximal LAD stent. But here I felt that, okay, now the problem is that I'll have to go into the bifurcation, and because circ ostium is critically stenosed, if I go ahead and stent from the left main to LAD, I might, totally lose the circumflex. And let's not complicate it further. Let's finish the circumflex first, treat it as the side branch, and then we'll come back to the left main to LAD. So I wired the LCX now, and then I did a pre-dilatation of the LCX with a 2512 semi-compliant balloon. And then I took a 27528 drug-eluting stent from the OM, mid portion of the OM, up to the left circumflex ostium, and just prolapsed the stent 1 or 2 struts into the left main. And here you can see how I have positioned the stent here. And this is the immediate post-stenting shoot, which is showing here that the stent is well opposed, and 1 or 2 struts may be hanging into the left main. But then again, if you see here closely, the LAD ostium is looking much more worse. But till now, the patient was hemodynamically stable. He was not having any significant complaints. So then I went ahead and did post dilatation of the circumflex stent with the 312 NC balloon, because I felt that I'll try to keep it as simple as possible, because let's say if some complications happen, at least whatever had to be done, I'll do it beforehand. And after finishing the post dilatation of the this thing LCX stent, I took a 4 × 24 drug-eluting stent from the ostium of the left main, overlapping into the proximal LAD stent. You can see here the stent being positioned. And if you see here, at the same time, the entire system has become thrombotic. There is thrombus at the proximal portion of the circumflex. There is slow flow in the distal LAD, and it looks all thrombotic. but I felt that, and at this moment, the patient, started complaining of severe chest pain. The BP started falling down. The ST went up, and the patient started becoming restless. But because I have a stent in the hand, I just felt that, okay, make sure the position is proper. And I went ahead and deployed the stent, and I withdrew the stent and did the ostial flaring. And then I took a 4 into 12 mm NC balloon and went ahead and optimized this left main to LED stent, and also dilating the overlapping segment. So because I had a wire which was all the time into the LCX, and I had the entire system under control, I felt that I'll finish once again. I'll finish the left main to LED part. And although the left circumflex had worsening thrombus, and after finishing the optimization here, you see the left circumflex ostium and the proximal portion has a lot of thrombus, and this is where the patient crashed, patients arrested, and we started doing CPR, and we had to intubate the patient. After a couple of minutes of CPR, we were able to bring back the patient. I had the entire hemodynamics stabilized by that time with the support of inotropes, and the patient was on ventilator. And this is where I took a 1.5 into 12 mm balloon, and recrossed the wires from the LED into the LCX, and took a 1.5 into 12 balloon, and opened the struts of the left main stent into the LCX, and made the space for the larger balloon. And then I passed a 3.5 into 12 mm NC balloon into the circumflex, and also passed the 4 into 12 mm balloon into the LED. And after opening the LCX ostium, I did a final kissing balloon inflation, and then a final pot. And this was my final shoot. If you see here, the thrombus looks resolved more or less. There is some degree of haziness still there, and the LCX ostium still looks slightly underdilated. I think imaging would have helped me much better here. But then again, I felt that now the patient is stable, and because I have had a sufficient result, so I felt that let's not meddle with it any further. And after removing the wire, this is what I had. If you see here, there is some amount of thrombus at the LCX ostium, which may not be apparent in the caudal shoot here. But because everything was stable, we had a good result. I felt that I think this is where I should stop. And then I gave the patient intracoronary GP2B3A and started him on GP2B3A infusions. And 2 days later, the patient went home, and he's now on 2 months follow-up, and both the father and the son are doing well. So the only thing I felt that in my minimal experience is that, we may not be able to get an optimal result as the guidelines mention every time. But whenever in the cath lab and in some sort of emergency, it is always better to salvage the patient, and whatever may be the best outcome for that instance, that you should accept and come out. Thank you.
Thank you, Dr. Gaurav Agarwal, for cases from mother and child technique. We have come to father and son PCI. So, so Dr. Shubhanan Ray, your comments quickly, and then we go over to our other two panelists. And Dr. Ray.
The similar, this is a blood chilling experience of angioplasty. So basically, I want, what we were discussing, you should practice on less, demanding fields like, LED D1 or easier things. If you go to left main again, that'd be a problem. Where the problem started. The problem, I'm discussing about the second stage, patient first.
Right, sir. Right, sir.
Problem started where about your strategy. You did not have a strategy. That is the major problem.
Right, sir.
In left main, you cannot do a left main stenting without a strategy. This is number one. If you do not have a stent, it is not LAD, LAD D1 bifurcation that you go with something casually and just put the stent. No, left main is a different ballgame. So you must have a strategy. In any complex angioplasty, you must have a strategy. In your patient, you should have planned a proper two-stent strategy, if you think. Now, initially you thought of putting a left main to LCX stenting. That would have been fine. But there was about 50% lesion in the proximal LAD. I think, in my opinion, proximal LAD should not be bare. You do need to do something, because that can give you problems later on. And if you make the LAD a side branch, if something develops in the proximal LAD, it would be absolutely difficult to go inside the ostial LAD from a ostial left main and do the things. So initially, from the beginning, you need to plan a two-stent strategy. Now, yes. What are the things you should keep in your mind? Number one, the proper strategy. And strategy, after strategy, the proper guide catheter. Number two, proper wires, proper opening of the LAD and LCX ostium. And then you have to plan the expansion limit of the stent. Now you place a stent from the LAD to maybe LAD, you have thought of say decay crash. You are doing a side branch as a LCX. Then you put the main branch LAD to LMCA. You put a stent in LMCA to LAD, say 3 millimeter. Your LMC is 4.5 millimeter. So you need a stent which will go, a 3 millimeter stent will go up to 4.5. And you know what? Even a giant stent does not go, a 3 millimeter stent does not go up to 4.5. It stops in 4.25. So you have to choose a stent. So after that, you choose a proper stent, you do a proper pot, you need to have a balloon. You have to have a proper placement of the stent. Then you do a proper pot, proper placement of the balloon during pot. Then you cross the inside the side branch. Do a proper kissing balloon, and what would be your balloon size during kissing balloon? Everything you must be strategized. Keep it in your head, or you write somewhere and start the case, and it will give you benefits. I can tell you that. Without strategy, don't go to left main. It will. Not only it is proper for you, and even for the patient.
Right.
I think Dr. Ray's point is very important. The last one which you mentioned, Gaurav, that I think it's very difficult to keep things on your head all the time. It's always good if you have a chart in your cath lab, which not only you, your other co-operators and the nurses and the technicians can also tell you straight away if there is something, steps which are missing. So a good printed kind of technique-wise chart, stepwise chart inside a cath lab will do a lot of good for the confidence of a lot of people, including you. I don't think we require to keep anything in our head today, because our hard disk needs to be really blank, because we have so much of things to worry about outside this. So, Dr. Kadir, your comments?
Thank you. I think that was very challenging, and I agree, because my level of experience is probably as much as Dr. Gaurav's, and I agree with what Dr. Shivanand said completely. I have a question related to the first case, actually, because there was an inadvertent encroachment of what should have been a left main stent into the LAD. So would you have then maybe finished it off with a kissing balloon inflation also, just to make sure that the distal part within the LAD is also fully opposed, and to make sure that there is access into the left circumflex later on? Is that something that might have been done?
I had done in post dilatation properly for the
Yes.
LMCA stent. So even after the post dilatation, the OCT run showed that the stent is well opposed and the struts are well opened. So I felt that there is no need to, further cross over into the LCX and do a kissing balloon inflation. So I felt for that case, I think that was enough is what I felt at that moment.
Okay. Just a thought that.
Dr. Behra, your comments?
No, I think he has done very good because see, many of us when we start, we actually face all these problems. So when you do left main, you should have always a plan. But because many times when I also want many things, I have seen many experienced operators also, they forget in hurry. Suppose the patient is crashing, no, they will forget these steps. So always, suppose you are doing left main, you should always tell one of your seniors to be around. If not in the cath lab, but be around so that if any kind of emergencies, he will come. And when your mind is stuck, many times our experienced cath lab technicians also, they will help. Suppose many times if the thrombus is there, there is VT, there is something, but your eyes should, like Arjuna's eyes, your eyes should always be on the operator, the first operator should always look into the your catheter position, where is a balloon, whether it is stopped, everything. But simultaneously, you have to also look whether there is a pressure data, whether thrombus, whether the ECG, whether BP, everything, whether the heparin ACT is properly maintained or not, you are regularly flushing your catheter or not. What is the everything you have to maintain? You have to proper because left main bifurcation, you have to plan it very, very, very methodically. And that last first case is okay, simple left main osteal stenting, but the second case is really a difficult case, and you have to choose your strategy from very beginning if you want to a decay cross or not. But I don't know why that thrombus developed. Do you have any idea why that thrombus developed in the carina? In both left main to LAD as well as the circumflex ostium, is there any? Have you maintained proper ACT? Have you regularly flossing your catheter? Is
Yes, sir. Like we were checking the ACT because this took almost 2 hours for me, the entire procedure. So we had checked the ACT. Even at the end of the procedure, it was somewhere around 280. So as like the cause of the thrombus, I am also not able to pinpoint because even the guide was almost all the time, it was not like non-selectively engaged, and there was no trauma to the stent or the vessel. So I am not sure why the thrombus developed in the first place. But while positioning the left main to LAD stent, that is where everything, started becoming worse.
actually there is too many wires in the catheter, We're putting two balloons, one stent, one balloon. So inside the catheter, it is too much of clumsy. 2 wires and 2 either balloon or stents all the time. So if you delay things, or if you regularly don't floss it, or you see there is pressure damping in your thing, so that something is fussy. So you should have these things should be done very stepwise and very quickly. All those things. No time to think in between, because it will thrombus with natural development. I have seen many operators. I have seen in many forums. Vinayak sir must have seen, and Subramanian must have seen in many forums. We have seen the same problem that during left main bifurcation stenting, many thrombus develop. Many operators, they have seen that many during. So I don't know. This is maybe due to a time lag or whatever the cause may be. Maybe ACT is one of the cause. One of the cause, proper apposition of the guide, if it is hooking to somewhere into the roof of the left main or into the side, so that the blood flow is not adequate and blood is tagging in the catheter. So this is very, very important, so that thrombus should not have developed. And after that, you have managed very well. I must congratulate, because many times in every operator's journey, there is time that let's say way to perfection is through imperfections. So don't be harassed. But next time you properly plan your procedure. So this time this is happening. Next time, this is my commitment that it should not happen.
Yes, sir.
Then you are not God. Then we are also not God. But at least I will plan my strategy. I'll do everything in near perfection. Then rest is up to you. Okay. So thank you, and very excellently done. I think the last part you have managed it very well. Thank you.
I think Dr. Mehra mentioned that thrombogenicity is actually a natural thing to happen. And to keep it, the fight is against to keep the blood dilute, to keep the clotting not happening is actually the challenge. Thrombogenicity is a natural thing. when your blood is exposed to foreign objects. So I think
Subaran, sir, what is your opinion for this thrombogenicity? Many of
Thrombus.
us, we have found that during left vein bifurcation, this thrombogenicity.
To me, it appears that basically what the genesis of thrombus is in his answers. If the procedure is too long, as for example in CTO,
Yeah,
what
yeah.
ACT you check? More than 300, at least, nearly 350. If you have a long retrograde CTO, what ACT you chase? 300 plus. So if you keep it at 280, there will be thrombus in a long procedure. So you have to, when there is a long procedure, your procedure is going long, you keep your ACT higher up, around 350. Do not be scared about bleeding. Bleeding never occurs in angioplasty. Be cautious about thrombus. Thrombus is dangerous. So your ACT was low. From your answer, we know that your ACT was low. So in a long procedure, keep your ACT above 300.
Sir, as you mentioned, I was scared of the bleeding and everything.
I know that. This is a common thing that happens. And I always tell my juniors that, yes, don't be scared about bleeding. Bleeding, you can stop by giving one protamine. But thrombus, you cannot get rid of easily. So keep your ACT above 300. That is a rule.
I wanted to ask all of you, like, one thing that first thing is like, like if you were doing this case, what would have been the technique which you people would have adopted in this particular, in the second case? And second thing is, sir, like in a bifurcation, a common problem that I face is that the wires get entangled either within the guide catheter or, so how to get rid of that, sir? Like, because most of the times it happens with me. I don't know what I'm doing wrong, sir.
Most of the times happens. Now you do one thing, I can tell you. Separate the two wires from the beginning, either by a mop or by a gauge piece, wet gauge piece, and never, shift the wires.
Okay.
These two are apart. Sometimes some people do place one guide wire, then on the guide wire they place a sheet. Say one of the sterile sheet you place on the guide wire. Now the second guide wire you put. So one guide wire will be above the sheet, and one guide wire would be below the sheet, so that you always differentiate between the two. So that once you do not mix up, and you mix up at the outside the Y connector. This is a rule. So, separate the guide wires by either a mop or a sheet, and do not mix it up. And there will be no entanglement.
So or you can have separate torquer, color torquers also.
Either you can put torquers also, but you must be very, very careful in case of torquers, because always you have to be careful that whether there is entanglement or not.
So, sir, basically you mean to say that, if they are positioned like this, I should not bring them outside or crisscross. I should
no crisscross. Do not
divergent.
touch them.
Keep it divergent.
Do not touch them. At one time, act on one guide wire. There will be no entanglement.
The best is put a button, put a seat. Okay, you like flip flop. This side you put the support this origin L6, and this side you finish L6 where then you go to and put the cover like this. Then this side where you put into the LED. So by doing that, I have seen in many, I have trained from Sri Chitra, my own professor doing this technique only. This is the best technique I've got. And torquer also. But sometimes torquers can be pulled out, because when you are pulling balloon, sometimes that torquer can be pulled out while the pulling the seats, because it is all fixed. So that is very, very important. And so that technique is very good.
It's a very valid question, Gaurav. I think. Which is,
also to remember, once you have recrossed, that you have recrossed which wire into what, because you're using two wires essentially during a bifurcation. At some point you would have recrossed, and then it all flips over. So I think the first assistant also has a role to remember which wire has been recrossed and where, at which position it is now.
I think, the most important in these kind of complicated PCIs, bifurcation PCIs, is first of all, leave your ego outside in your office, enter the cath lab, with a team of people. and all team members have their designated roles as to exactly what they have to do. That is very, very important. I think, you cannot be a Superman there or a superhuman there. It's not possible.
Absolutely.
So designated roles for every person should be there, and then only it will work like a well-oiled machine. Otherwise, these kind of little problems which you have mentioned, like a ACT monitoring person has to be there. You cannot be monitoring the ACT while you're doing a complex angioplasty. Somebody, a nurse or a technician should be telling you all the time, sir, the ACT is this much, so you can act on it. So this is not your question to the operator, to the technician, how much is the ACT. They must tell you from time to time. You must tell them within 15 minutes, half an hour, every half an hour, the ACT has to be measured. So designation of roles in complicated bifurcations, I think, is one of the very important things Shubhan and Ray just mentioned. So I think with this,
One last
we
question.
should,
Sorry.
okay.
One last question, sir. Let's say you are doing a LED D1 bifurcation and you have kept a provisional stenting strategy, and the stent is from the proximal left main to the mid left main across the diagonal, and and after stenting the diagonal gets pinched. So before crossing the wire into the diagonal, the left LED wire into the diagonal, ideally what the textbooks recommend is to do the optimization so as to open the strut so that the wire passage becomes easy. But at the same time, what about the diagonal wire, which is which I have kept beforehand into the diagonals because it is jailed? So shall I remove it, or first cross over into the diagonal and then remove the jailed wire after doing
No, the point is, in any bifurcation,
Yes, sir.
without doing a pot, you cannot, cross. Why you cannot cross? Because your job there are two problems. One, if you do not do a pot, the proximal stent will not be properly opposed, and there you can cross through the starts. This is number one. And more important is, when we do a pot, usually your crossing will be distal through the distal starts, and it is easily done. So don't worry about the jailed wire. You just dilate the proximal stent at nominal pressure, and see that whether the flow in this thing is compromised or not. If the flow is not much compromised, you go again with a high pressure and then come cross through the distal starts into the side branch and come out with the gel wire. This is the rule.
Okay, sir. Thank you.
Thank you, Dr. Gaurav, because I'll not allow you to ask any more questions for the simple reason is, listen, the next time, I think you need to take Dr. Subhanan Rai out for a dinner and pick his brains, That is very, very important. Because you have asked so many questions and taken so many tips from him today that I think this is worth at least 6 months of experience. So thank you very much. It's already 10:30 in Dhaka, Bangladesh. So it's late for Aisha also. Thank you, Aisha, for staying up so late into our meeting. Dr. Dibaranjan Behra, as usual, has been an excellent supporter for all our meetings. And Dr. Shubhanan Ray is our mentor and expert, which we always love to interact, and is never short of answers. He is always so patient with all the persons who are learning. So thank you so much, and Abbott, for arranging this wonderful meeting. So we call it a good night tonight. Thank you very much. Bye-bye.
Thank you, everyone. Thank you, sir.
Thank you very much.
Thank you.